So it's great to have you here, at least virtually, back in Germany again. And I think I know most or not all of your presentation, but I'm really looking forward to it. And yeah, now I will hand over to you.
Great. Thank you so much, Christian. Can you hear me okay? Sound-wise? Fantastic. Christian and Sebastian, thank you so much for inviting me. I'm very excited to be here and also meet some new colleagues online, and really looking for this sharing. As a bit of a background, I am an emergency physician. I'm located in Vancouver, British Columbia in Canada. And later on, I'll show you a little bit of a map of where I am. And there's a tradition in Canada when we present that we acknowledge where we are located in terms of our Indigenous lands. And so I am Vancouver. I'm located in the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Across Canada, we have over 650 First Nations, and it's also recognized as the Turtle Land. And I feel very fortunate to be a settler here in Vancouver. I have been here and do my emergency medicine profession for over 35 years now. And also, I'm very interested in the whole area of digital health research. And so I'm just going to show my slide. And again, Christian, if you can give me a thumbs up if you see my slide. So I am a professor at UBC Faculty of Medicine, and my area of research is about digital emergency medicine. I've been doing that for about 30 years. And I'm also currently the medical director in our BC Ministry of Health in the virtual physician program, which is what I'll be focusing on today in a bit of discussion. So I'd love to have this discussion as a little bit of a free flow and conversation. So I'm going to present my materials, and then we will have some question and answers together on this. The theme of this morning's discussion is how can we put our services into patients' reach in a very rapid way. And this is a topic that I'm very interested in, of course, being in emergency medicine, and I welcome your perspective on that. Life always have unexpected occurrences. Health challenges is one of them. A new parent with a baby for the first time had fever and vomited twice. This always happened in a weekend where you can't get a hold of family doctors. Or a gentleman with history of family history of heart attack. And for some reasons in the morning at 2 a.m. in the morning, woke up with chest pain. Lasts about half an hour and it went away. So in these two situations, the patients or the family or the parent would have in mind, do I need to go to emergency? Do I need to see a doctor, or do I need to seek a doctor's or nurse's opinions on this? And often, because of the family doctor not necessarily reachable, or in Canada, approximately 1 in 5 persons, unfortunately, don't have a family doctor. And so they often have to say, well, where do I seek care? And often end up in emergency department. Is there a better alternative? Can we do better? Let me just introduce to you British Columbia. I hope many of you, Christian, certainly you have, and I hope that many of you may have a chance to visit. And if you don't, I'd like to invite you. Please look me up when you're here. So as you can see, there's the map of North America. In Canada, we're spread across with 10 provinces and 3 territories. Our province, British Columbia, is the green one that's located in the westernmost part of Canada. And you can see the population here in British Columbia. I put some Germany figures. In terms of space, geography, our province is approximately 2.6 times the size of Germany. So this is a size. But for population, we have 5.7 million population, which is about 6 to 7% of yours in Germany. And so if you do an average, that means in British Columbia, every square kilometer will have 6 people standing there. Whereas in Germany, that's 232 persons per square kilometers. Now, if you look at the British Columbia map, I live in the bottom red dots, which is at the south western corner of British Columbia, just next to the island. That's Vancouver. And in Vancouver, we have approximately about 2 million population there. So you can see that even if we just divide it up, and in fact, with 2 million concentrated in urban area like Vancouver, like a capital of Victoria or Kelowna, these are the 3 biggest urban centers in British Columbia, that you can see that the rest of the population is even more sparsely distributed. And so in that context, how do we, thinking back to the 2 cases, the mom with a child with a fever, a person with sudden chest pain, or a kind of a acute, a worrisome symptom, how would you seek care? And how would a health system provide that type of care? And you can already anticipate that in the in-person care, there's uneven access to these services. And also as a province, how do we develop those services effectively and cost effectively? Those are some of the challenges that we face. And I'd love to hear your thoughts in Germany, whether you may also face some of these or the drivers may be different. And so what I'd like to explore with you today is one way of addressing it, which is a telephone line called 811. And it's organized by a organization called HealthLink BC, which is a part of the BC Ministry of Health. And so what I'm looking forward to doing is in the next, I have about half an hour of material, and then love to then do some question and answers and discussion with you, is why 811, and also why would we have virtual physicians there? And secondly, how does this work? And third is, what's the impact of this? And then I'll show you a little bit about where we're evolving over time. And then I'll stop, and then we'll have some dialogue together. So 811, this is a service that's been going on since 2001. 2001. It started off as a health information line, and nurses were and continue to be a cornerstone of that service. Where if a person calls in, and 811 is province-wide, anywhere in the province you can call 811. And when you call in, if you first encounter a administration person who helps provide you with administrative information. Where's the closest clinic I can go to? Where can I get immunization? If you have a health problem, my child has a fever, I have chest pain, then you'll be sent to a nursing line where the nurse will talk with you and will then provide services and support the patients. What changed? Well, COVID changed it dramatically. COVID in March 2020, as all of us recall, suddenly changed the whole world. And number one, it decreases clinic access. Many community hospitals, community clinics, doctors' offices closed. Secondly, it was a new disease. It was a disease that needed to be explored, and there's a lot of mystery to it. And also lots of symptoms that may initially be very similar to many diseases. And so very often, very frequently, and 3 is there was an increase in volume. In fact, the telephone line jumped 7 times in terms of the call. Normally we'll receive in province British Columbia about 1,200 to 1,500 calls a day. But when COVID hit, we actually hit 7,000 calls a day. The reason I know the number 7,000 is because that was the capacity of the line. We couldn't take one person more. And so we didn't know the real demand. And so with that few factors, the nursing scope of practice is what we offered. And so it was rapidly reached. And so a group of us as physicians were invited to join the nurses to provide this interprofessional care team, which we call virtual physician service. And the more affectionate name is Heidi. Is HealthLink BC Emergency Eye Doctors in Assistance. And so Christian and I were joking. It wasn't on purpose, but we picked a very, very good German name for this. And so Heidi, what do Heidi do? There were 4 purposes of why we do this line. Number 1 is we want to work with nurses to provide, especially when the nurse felt that the patient need to see a physician. Now, if the nurse felt, wow, you have crushing chest pain still going on, they would just connect the patient to the ambulance services, here 911, and take the patient to emergency. Or ask the patient, you got to call 911. If it's not that type of urgency, but it's a question, chest pain half an hour now goes away, and the patient's very comfortable, for the first time, then it passed the call over to the physicians. And so we as physicians, number 1, talk to the patients and try to address their clinical needs. And invariably, there'll be anxiety associated with it. And so this is our job number 1. Number 2 is at that point, and in fact, even up till now, and you'll see more and more relevant, is to preserve the acute care capacity in emergency departments. How do we make sure that for those patients with clinical conditions that don't need emergency care, how can we support the patients? And how can we, number 3, help the patient to safely navigate the health system? I remember the first time I went to Munster, and I'm very glad Christian was there, of course. And when I went to a new city, I rely on my friend, Christian, and also my mobile phone so that I can navigate with Google Maps. And in many ways, for patients, especially first time entering a health system, it could be as strange as me arriving in a new city. And so as a physician, as nurses, we are their friends to try to help them navigate. And of course, we'll provide tools also to do that. In an urgent situation, it's very important for us to help our patients at that particular time, at that moment, to help safely navigate the health system. Do they need to go to merge? Or this is something that you can stay home? If your child has fever, try some Tylenol, try some antipyretics, and if 1 or 2 days it goes away, you don't really need to see a doctor. But watch out for these things. If it changes, you got to go to merge or you got to see a doctor. So that type of navigation is very, very important. And also, it's very important to link them back from this one episode of care back to the family doctor. Is to say, in 1 week, 2 weeks, you may want to follow up with family doctor. Now, you cough up a little bit of blood in the lungs. That's not something urgent that you need to go to emergency. But this is not something you can ignore. Make sure you see a doctor within the next few days or 1 week. And of course, if you cough up more blood, this is a volume, you got to go to emergency. So these are the cases where we can help address the patient's current need, reduce anxiety, and also point them the right way in the health system, and make sure that they link back to the family doctor. Those are the 4 primary purposes of what we do. All right, I'll show you a little bit of what we do in terms of actual pathway of the patient. As I said, the person call 811, and then depending on whether they're asking for services, if it goes to nursing service, the nurse will talk to them, and we would divide them into roughly 6 categories. Call 911. Red ED means the nurse feels that you got to go to emergency now. Or red MD means, well, you got to go to see a family doctor within the next, or general practitioners within the next few hours. If you can't, you probably need to go to emergency. Yellow means, well, you need to see a physician sometime today. Black is you need to see a physician within 1 or 2 weeks. And green is you probably can be treated at home. How we changed it in terms of adding virtual physician is that for the categories, initially we start with red MD, but we rapidly include red ED also in that. And in some cases, if they need to see a physician within 24 hours, yet there may not be a physician available in that community for 24 hours, then they'll refer to us. And so for us, we again to recategorize the patient. And so when the patient calls, we will then connect with them by phone first, lowest barrier of technology, and if necessary, we'll then escalate to video, such as in fact, in British Columbia, we use Zoom, such as what we're doing right now. And so with that, by the way, I forgot to mention one thing in the beginning. My computer is acting up a little bit, so sometimes it will kick me out of a Zoom. So if I suddenly freeze, please wait. I'll sign back in, and then we'll go there. So in terms of the categorization, this is how we do that with video. Approximately, I'll talk a little bit about our statistics. But for example, if we get a call, oh, doctor, I got a cut in my face. It's a little bit jagged. It's close to my lip. It's about 2 hours ago, and now it's clotted over. Do I need to go to emergency to get sutured? I really don't. I really don't want to go to emergency without needing to be there. So video is invaluable in that case, that you can actually take a look and then say, well, gee, it's obvious. This one you need to go, or no, you don't need to. Just watch out for these things. I got a case when a mom called in and said my 2-year-old toddler fell off the bed half an hour ago, and it was about 5 feet, and my child was crying unconsolably and didn't want to walk on the ankle. It's quite swollen. And so, when the nurse passed the case over to me, I read it. I said, yeah, sounds like probably need to go to Merge. And so I talked to the mom. Sure enough, that was the history. Mom was very technically savvy. I said, well, can I go on video and take a look? And the mom was, again, very, very good. Within about 15 seconds, we were able to connect onto her video phone. And right when we connect, the mom then turned the phone to where the child was. We lost the child. For the next 30 seconds, we were chasing after the child because the child didn't want to show up on video. And so he was running down the hallway and then run up the stairs. And mom was barely able to keep up. And so I said to the mom, well, that was half an hour ago. And right now, the child seemed to be running quite reasonably well. So why don't we just watch it a little bit and see how it goes? If in the next few hours, the child forgot about it and start playing, eating, then just watch it. If for some reason, even after the child calms down, if they're still limping or abnormal gait, yeah, you probably got to take them to Emerge. Again, that was a call that within about 2 or 3 minutes, we're able to kind of figure out a plan for what the child needs to do. So video is invaluable in those cases. These are some of the statistics. By the way, we only took a small percentage. I really want to acknowledge our nurses. They took all the calls that are health related, and we only take about 12 to 15% of all the calls that the nurses take. So I want to acknowledge our nurses. By the way, this is Nursing Week in Canada, and so I also want to recognize and show my love to our nurses. And this virtual team allow us to connect. And about 20% of the time, we need to escalate to video, especially in children. The dreaded phrase that we hear from parents are, my child is lethargic. That phrase itself can kind of raise hair behind our neck. And so by turning on the video, if lethargy means the child is still jumping on the trampoline, but it's only about 2 times, 3 times a day, as opposed to 15 times a day. Or if we turn on video, the child is just sleeping on the sofa, moribund, and have trouble waking up. That's very different. And so lethargy can be interpreted different ways. Again, laying our eyes onto the patient is very important. By the way, also, it's a privilege for us to be invited into the patient's home. How often do I see a patient in Emerge and they say, well, a jar fell onto the child's head, or my father fell downstairs. For me to be able to be at home to say, could you show me what that jar looks like? Could you show me the stairs? Those help me put context into the patient's case. And so video is very important. And we hit a milestone in 2024 in September. We've seen 200,000 cases there. So we hit that milestone on that particular day. And we have 18% year-on-year increase of our population. You can see the top left graph, the green curve was 2020, and the top pink curve is the last year, 2024. You can also see the breakdown of the gender. or I should say sex in this case. In the bottom right bar graph, you can see that the yellow represent male callers, and the blue graph represents the female callers. Now you can see, of course, there are 0 to 20-year-old. Of course, 0 to 5, it was the parent who calls in, so it's not the child themselves calling in. And also on the other segment, for the older population, there's a significant number of caregivers calling in for the patients. And so that's also part of the reason why the blue graph, females, tend to call more than males. And when we did a survey of the patient after their call, we got good satisfaction of the patients. And so we have been not only looking at the current services of the initial HIDE service, but when the antiviral therapeutics came out, you may recall that in 2021, that was the first time that an oral agent was available. And so we converted our line to prescribe the medication when the communities were still trying to get used to prescribing, and also the supply was limited, that we use this provincial service to distribute the medication throughout the province. Again, think about, in Vancouver, when the first 200 doses of this oral medication arrived from British Columbia, how would the government distribute those 200 doses in that first few months? Now, by April, we had enough supply to support all the demand that's necessary. But in those few months, our line was used to try to not only diagnose, to prescribe, because there are a lot of medication interactions. And also, we put some medications into different parts of British Columbia so that we can get those that are not living in the urban area can get access. In 2023, we also started a line to support patients who don't have family doctors, but on medications, and they need medication renewal. And so we partner with our community pharmacist to do the renewal for those patients. If they're family doctors, we say the best place to get renewal is your family doctor, because they know you, they know your history, etc. But for those who don't, it's a challenge for them. Think about it. They are healthy, they are well taking the medications, but they know that if they stop the medication, they'll be unwell within 1 or 2 weeks. But if there's no family doctor, if there's challenges getting a walk-in clinic, the only place to go to is an urgent clinical walk-in clinics or emergency department when they are not sick. And so you can see, when you walk in the emergency department and tell the nurse, I'm here for a refill, the nurse will say, why are you here? Right? But socially, they're having trouble with that. And that's why we partner with community pharmacists so that we can help these patients to renew the medications. If the pharmacists don't feel comfortable renewing certain medications, or may need to know the kidney functions before they want to renew, that's when we partner together, we see the patients, order lab tests, check things out, and then renew the prescription by phone. And so finally, in 2023, we also partner with our family doctors, so that for family doctors, many of them don't take after-hours care, don't take after-hours call. And so what we do is we partner with them so that we take their call with the promise that the next day they would actually take the patient back if the patient needs to be seen within the next 24 48 hours. So in that way, patients win, they have access. Family doctors and nurse practitioners win because we cover overnight, and we win in 811 because we are able to then refer the patient back to the family doctor the next day if necessary. And so in some ways, it's like a Swiss Army knife. We can use our service in a different way. Here's a diagram. I'll unpack it. It's a bit of statistical diagram called Sankey diagram. And so if you see on the left side of the graph, these are nurses who identify patients that need to see a physician now or need to go to emergency department now, as we talked about earlier on. And then what we did do is then we track afterwards for the right side of this graph is what physicians decided what the patient's outcome needed to be. So if you go from the bottom, we send about 21% of the patient over to emergency department. Yeah, sir, your chest pain is suspicious. Even though it's 3 a.m. in the morning, you got to go. Don't wait till the morning. Don't call your family doctor. You need to go now. So 21% of the time we do that. And then 40% of the time we said, well, for your child's fever, is the first, 2 or 3 days, it's 6 months old, so it has okay immunity. So try some antipyretics, watch for these signs. And if none of these signs develop, and after 2 or 3 days, the fever is gone, no problem, stay home. And sometimes what we do is we offer, can we call you back the next day so we can quickly check with you, make sure the child's doing well. So those are home treatment type cases. There are about 9%. We said, yeah, you gotta go to see a physician now. You've been coughing for 5 days. You're starting to have sputum, and you're starting to have fever. I'm worried about the potential pneumonia. You may need to get a physician check you out in the next 1 or 2 days maximum, so that if you need antibiotic or X-rays, etc., you can get that done. And then the top is schedule for appointment. In 1 or 2 weeks' time. Today we've looked at that, and you have zoster. I've prescribed you some antivirals. If things get worse or the rash is not resolving as we anticipated, you need to see a family doctor in 1 week's time. So those are categories that we do. And so you can see the flow of generally how those patients are flowing from where the nurse go to physicians. That helps a little bit. In fact, in the first 90 days, we're able to give this type of statistics to government. But what we also want to know is there concordance? The second word, concordance. If we advise a patient to go to emergency, how many of them would actually go? If we say go see a family doctor in 1 week, how many of them would actually go to see family doctor in 1 week's time? And so very fortunately, we're working in Ministry of Health, and under anonymity, we're able to track these patients and find out what their behavior would be like afterwards. We found that in the top column, about 65% of the time when we said go to emerge, they actually would go to emergency. But you can again see that some of them end up not going. Now, this could be this Dr. Ho, I don't want to listen to him. He's full of, baloney. Or it's because they live 2 hours away from emergency department. Going to emergency in the summer could be a challenge. And if it's in the winter, the road may be frozen over. So we also look at about go see a family doctor. If you need to schedule in 1 week time, how many of them would go? We found that about 1 in 2 patients would end up seeing a family doctor in the next week to 2 weeks. Now, again, this could be because, I'm getting so much better, I don't need to see a family doctor. Or because many folks says, if I call my doctor today, it may actually take me 2 weeks before I can get an appointment. And so some of these are directly related to why our advice is useful or not. But significantly, there are systemic factors that affect this concordance. I'll come back to this point a little bit later. And so it's important for us to track this position. It's very important for us to track concordance as we move forward. We publish our findings in these papers, and so you can, if you want, you can check out the QR code. And of course, these slides will be available, so you can look at it later. If you're interested in our statistics, the first description of our service, and then also we start tracking the concordance rate. And then the final paper in the bottom right corner is what are some of the factors that affect concordance? How do we advise, etc., so that we can learn better how to treat our patients. And it goes to now my final section of my presentation is how do we learn? How does a health system learn? We have our service here. How do we improve our service so that we can do better over time? This is a Agency of Healthcare Research and Quality in US actually describe a learning health system. And the definition is a good one. A health system in which internal data experience within your health system, the data that we're tracking, and how is that integrated to external evidence? When we do a literature review, what do other teletriage service do? What are their success rate? And can we approximate that rate or not? And incidentally, the concordance rate in teletriage, usually in the literature, is only about 60%. And so we are doing, a little bit better on the emergency side, a little bit worse on the family practice side. But the question is, how do we maybe not only meet what the literature does, but beat those statistics to increase it? And so that's important for us to compare and then put those knowledge into practice. And so how does that work? This is Chuck Friedman, who actually is the father of learning health system, and he actually started a journal of learning health system. And I see this is a very good description of it. So you notice the circle, and in fact, just go back one slide. Again, you notice there's that circle here, and it's centered around practice, data, and evidence. And so in some ways, this diagram more explicitly identify that, in fact, what we do is we form a learning community in the bottom right, so that a group of us are interested to improve. And usually it's not just a uniform group of health professionals, not a uniform group of health policymakers, but in fact, health policymakers working with health professionals, patients, researchers, and data analysts together, so that we can put this group together to say we want to improve 811. And so what we then do is we then look at our practice, capture practice as data, what we call practice to data, and say today, what was our statistics? What was our statistics of patient being triaged? What's the concordance rate? And then what we do is then we do discovery. We go to external evidence and go to literature and say, what does the literature say should be the gold standard today in terms of that? And so that's data to knowledge. And then what we then interpret results, then say, well, how do we put this knowledge into practice? So today we may be about the same as general public, the literature, but are there things that we can do? For example, if Dr. Ho makes an extra point to say, you got to go today, and are there any barriers for going? And by understanding the patient's situation, that we can increase concordance, then we put that knowledge into practice. And so that's the K2P, which is the top right corner of that circle. And then that circles back again to the bottom. Then we remeasure it to say, in 3 months, what is now our concordance rate of patient going to emergency? And can we continue to improve it over time using the factors that we know about concordance? So that's the dynamic circle that help us. And it's not just health professional, policymakers, data analysts, all of us together with patients need to work together. And so these are the very specific tools within the learning health system that's very important. One, having a dynamic dashboard. I'll come back to that a little bit. So we track the data. And secondly, we really need to know the network. Today, who's in this learning community of practice? You can see this diagram in the middle, a whole bunch of bubbles. Each bubble represents one person or one organization. How do they link up in this network to create the 811? And then what we do is we remeasure it 1 year's time. Have we increased the number of bubbles, i.e. the network's expanding? And in each of those bubbles, has it increased in size? That means they're getting more participation, more influence in that particular circle. And also geographically, do these circles locate throughout British Columbia or just all concentrated in Victoria or concentrated in Vancouver? Those are the nuances of this network that's very important. And very importantly, it's not just look at statistics put into practice. How do we continue to have this dialogue deliberately so that we can actually discuss and share? Here's an evidence, here's a part of our dashboard where we show geographic location of all the calls that come in. You can see the center graph of British Columbia. You can see that on the middle column, these are different communities. If you click on a community, you'll know how many cases came in the next month, in the last month, or in the last year, or since beginning. You can see on the top right that there's this sliding scale that you can actually limit your dates, or you can slide it to the original date. And then also we track, when did it, what's the average encounter time, and also when did they usually come in, etc. This dashboard is important. And also we track this. As we talked about in the province of British Columbia, that there are patients that are distributed throughout different areas. And there's an index that we try to measure. It's called the Canadian Index of Multiple Deprivation. We take into account the patient's access to healthcare services, their degree of disability, and also their financial status, educational cases. So all of that lead to a index. And so when the CIMD is 1, those are the least deprived, meaning that they have the means close to health facilities, can get to it fairly easily, and usually financially pretty good. 5 is the least, sorry, 5 is the most deprived. 1 is the least deprived, 5 is the most deprived. And so those are people that live far away from healthcare system and have challenges getting there because of disability, a variety of reasons. You can see on the top left, that bar graph, the slide, that curve is from 1 sliding down to 5. Most of the health system behave that way, and the general BC health system behaves that way, and the general 811 statistics, it behaves that way. But when you look at the bottom right with the 5 graphs, we have divided up into 5 geographic regions, which is our health authority regions. And you can see that some of them, for example, the 1st, the 3rd, and the 4th, the bar graph slide in the same way. But on the Vancouver Island and in the interior, you can see we actually tip the curve the other way. So the most deprived, and in those cases, they tend to be farther away from hospitals, have some kind of older population, that we actually tip the curve in those cases, that we serve those who are more deprived better than those are least deprived. What we hope to do is not only to balance the curve out so it's flat, but also in certain instances want to favor those who are inequitable in access to care for now. And this is one of those indexes we track very, very closely over time to make sure that we not only maintain a good curve, but actually improve on those situations. So this is just a graphic illustration in terms of how many residents encounter an 811 per 10,000 patients. You can see that whereas in general, you have different color shades, suddenly you have this red box in the top left corner of the province. That area, very hard to get to healthcare, but they're using services heavily, exactly because of that reason. Finally, this is all about how do we deliver equity and access of care. Digital health promise is that it would deliver care to the patients where they are. And so a group of us, 50 authors, actually did this series of paper called Essential Digital Health for the Underserved, trying to understand, what's essential and what's underserved population and how can digital health help. Essential is a societal decision. If there's no cost involved, then all healthcare is essential. But often, because there's a public component of funding, that there are certain types of healthcare is not essential. I think most of us would agree, plastic surgery for cosmetic reason is not essential healthcare. But heart attack, you get, good management is essential. And so once as a society, as a country, that we have agreed on what is essential, then underserved is easier to be defined. Those that are not getting those type of services when you need. Again, think back to the province, you have that geographic distribution. And then finally, in that case, then, how can digital help in improving the equity of service of care? Again, that series of papers and that QR code, very happy to discuss that with you and listen to your feedback on that. Finally, our next steps, we are moving towards a digital front door for our province. Many health systems, many 811s are doing that. And so we're linking up with our ambulance system so that we can help each other. Many patients call into 911, but actually some of them don't need ambulance to transport. So how can we at 811 help them? Just as in 811, when they call, we may transfer the patient to 911 because of severity. And so patients don't need to choose, or they can choose either 811, 911, but they'll end up with the right front door for us to get them and help them. We want to connect more and more with emergency departments, with our urgent primary care centers, UPCCs, and our primary care providers, family doctors, nurse practitioners, or primary clinics, so that we can do more bi-directional referral, so that patients don't need to line up in emergency after they talk to us. We're looking at machine learning to do better classification and stratification of patients. We look at economic calculators so that we can actually generate more cost effectiveness analysis to demonstrate value for this. I won't go into Jeff, but if you're interested, it's about measuring environmental impact. And we're forming a national network of 811 across Canada. There are 11 of us in province British Columbia. We are actively forming that network. And finally, thanks to Christian, I'm actually linked into Germany, linked into your 11.6, 11.7 system, had a chance to meet with the Westphalia section. I also had a chance to go to UK with the NHS 111 and also in Australia and Health Direct, all very similar concepts, a call and number to support our patients so that they can address the urgent care. And so this digital front door is to decide, do you really need to go to Merge or maybe not? Maybe you can go home, maybe you can stay home, maybe you need to go to the clinic. We can give patients a choice to make a good decision at the time of urgent, unexpected health problems. And so what we hope to do is that virtual care would ease the uncertainties of the patient, not only on clinical, but also on emotional level, and then love to then support them to go to the right place at the right time. Thank you very much. I'm going to stop here and really appreciate your attention. Look forward to some dialogue and discussion on this subject matter. Thanks.
Thanks, Kendall, for the excellent talk. It's always something new to me as well. So, yeah, from the audience, any questions to Kendall?
So maybe we just start with some questions. I think so. Thanks for the great presentation. It was really a highlight following through. But directly getting into one detail, you mentioned concordance, which you can measure quite partially. And you suggested like it's important maybe as well for the learning and improving of the services, right? So in which region, for example, in which age group or demographics, knowing how well the concordance is working in these groups, and there may be even disease related, as you mentioned, that are all important factors. So maybe you could get a little bit more into detail what approaches you have given a try and what worked out not that well and where were the real successes. Yeah, maybe that's for the first time.
Excellent. Thank you, Sebastian. The nice thing about data, and especially data analytics, is that you can zoom in and zoom out. I was reminded of people taking photos, cameras, that you can kind of lean back and then kind of look at the whole picture. And then if you want, you can zoom right into the little flower in a garden, actually look at it. And so what data analytics does is exactly what you said, Sebastian, that we can get the provincial database to look at a group of patients, the whole province, and say, in general, how many of those after going to 811 would go to emergency department? So I gave you an overall number, but then we can now zoom into the different health authorities because the management of those emergency department may be slightly different between health authorities. We can zoom into one hospital if we want. Of course, it's anonymized. So we can zoom in to that particular point, or we can step back and say, let's look at all the chest pains in the province. Let's zoom in on the chest pain and see what the concordance is for patients coming in with chest pain. And do we have a good rate? Or even at times with respiratory illness, all of us, in a certain season, will have respiratory rise. And so again, we can then look at syndromic challenges to say, for all the patient with shortness of breath or fever, what's the concordance rate? And so in that sense, we can then not only look at the data itself, but the learning health system becomes very important. On a syndromic respiratory season, can we open certain clinics or increase certain paths so that we can use the dynamic dashboard to correct or alleviate certain areas? We're very used to it in some ways for all of us because of COVID. We look at daily COVID infection rate, we look at daily hospitalization rate, we look at ICU rate, we look at mortality rate. I think that really is the essence of what this dashboard is about, but we can now fragment it with the data that we have. And that's why the data dashboard becomes so important. And in the future, to be able to apply that for patient stratification using machine learning AI, for us to look at provincial health management, again, this becomes a solid basis upon which we can build on top. Sebastian, does that help?
Yes, yes, that's good flashlight to the AI data analytics part. But do you have any follow-up on the specific patients? For example, do you record the Canadian Social Security number or something like that, so that you could link through a back channel to the clinics, evaluate if the patients showed up there, or do you have something like patient-reported outcome measures, for example, linking to the patient by giving him a URL or whatever to follow up? Do you have such a possibility?
Yeah, excellent. Thank you. So maybe I'll talk a little bit about the outcome measure and then the process of doing that. We use what we call quintuple aim evaluation framework. We look at 5 things: equity of access of care. So I talk about the Canadian Index of Multiple Depravity, CIMD, as one index of that. And second, we look at patients and health provider experiences. That's why we do patient a survey afterwards. We also survey our health professionals, our virtual health professionals, in terms of the service itself. We look at effectiveness. That's where that's going to be very important in terms of outcome. I'll come back to that point. And then finally, cost effectiveness. That's why we track how much does it cost to do this 811 service. How many patients do we serve? And so that's the cost side of things. But then to ask the question, if we don't have 811, how would patients seek care? And then have a calculation of that to understand how much would it cost if you didn't have the service. And it's the comparison that leads to value for money. Now, all of us don't buy the cheapest car in the world or the cheapest house in the block. But we have our certain values. We say, yeah, it's too opulent. I don't want to get that car, but I want to get this car so that it's decent, right? And so in some ways in the health system, it's value system that we choose. And so to demonstrate how much money we put out and do we achieve that value, that's the value for money proposition. And then finally, I'm going to come back to the quality side. You see those Sankey diagram? So we want to see those diagrams where the patient were recommended to go to ED, but they end up not going. That's when we go into the provincial database and we have to go in with a researcher that when they're inside, they'll be able to look at a identifier, track all of the journey of that patient. But that researcher has to swear that he or she won't break privacy. And so by the time he or she comes back out, that all the data is anonymized. I compare that to quite a few years ago. I went to Las Vegas with my kids, and we went into the M&M store, the candy store. And so the traditional way is you go into a store and said, "I want, M&M, but I just want red M&M." But of course, the store said, "No, you just have that one package." But when you go into M&M store, you can in Las Vegas. You can say, "Just give me red," and then they'll just give you red and yellow, etc. So that's the difference between this way, where we have to externally ask for data, and they'll just give you one package of data at a time, as opposed to we go in with approval, etc., and then look at as many type of combinations as we can, and then come back out with the same kind of data. And so that is essential for us to carry that. And then finally, we also audit those cases that what I worry the most, you can stay home. And then within 7 days, they actually went to emergency. I would then say, why? Why did they go to emergency, right? It could be that the status has changed, in which case, my chest pain become more frequent, so I follow doctor's advice and go to emerge. Very appropriate. Or I said, yeah, your chest pain is not heart attack. And then 3 days later, they show up, well, you had a really bad heart attack over the last 3 days. Now, that would be a case I need to audit. And finally, we audit all our mortality cases, everybody who died. We want to look at, did we actually cause the delay of treatment that lead to mortality? So all those are things that we try to track. Sorry, that was a long answer.
No, it was perfect answer. So I have a follow-up question, but I will delay it a little so to give the others space to ask their questions. Thank you.
Thank you. I do have a question for the audience, but I'm happy to take questions from the audience too. Thanks to Christian, I get to visit 11.6, 11.7. And in some ways, it's a similar system where patients may call 11.6, 11.7 to get some advice, if necessary, come to hospital. I visited Westphalia one and had some discussion. Christian, do you recommend to your patients, or are patients aware or use 11.6, 11.7, or do you see that system we can learn together to kind of evolve that service in the same way? Welcome thoughts from the audience, or Christian, you and I had some discussion about that too when we were visiting Westphalia. So.
Since we already had that discussion, I would like to learn thoughts from Sebastian, Andreas, Hermann, Sally. So it's a small audience, so just go on.
Yeah, so maybe I can just, I'm impressed, I have to say. That's very good. Because if I would ask my wife or even myself, I don't know even about 11.6 or 7, right? Of course, the 11.2 or whatever. So the real emergency, everybody knows the number, right? But the others not. And if depends on your health insurance, I guess they offer sometimes kind of a call possibility to, for such cases. But I think I like the approach that there's one number and that you get the service from everywhere. I think it's split more in Germany, and I also know it in Switzerland, which were, I think, a little bit more advanced than in Germany, as they started earlier with the telemedicine stuff. But I think it's also not company-wide. It's more like depends on where you're insured and what they offer, right? I think that's a big difference, because if you have one number, everybody knows this, easy, right? Otherwise, people, I mean, of course, in normal life, you don't care, right? And then if you really need, you don't have it. And usually in Germany, okay, it's not like in British Columbia where you have these super remote places, but there are also remote places in Germany, of course, especially in some remote places, there's no doctor coverage, or that's a big problem, that the doctors don't want to live there or serve there anymore. So there's also these kind of problems we have, of course, right? Even if the population is a lot more dense, and also the doctor population. But yeah, that's I'm really impressed how this works in Canada or in British Columbia, I have to say. Yeah. So I think it would be good if we would have a similar system, especially also how you look at your data to improve it and to learn from it. I have the fear that sometimes in Germany, especially this last part is missing, right? So that we do something, but we don't spend effort to really learn from it or to get the data out and to improve it, right? Some are doing it, but for most of the stuff in medicine, I have the impression, and I mean, I'm also in this medical informatics field for a lot of time now, right? It's a different approach. Yeah. So I really like what you're doing there. I have to admit.
I would totally agree. I think it's very beneficial that you have the ability to collect the data and that you consider the data in improving the system and maybe even giving feedback back to the nurses because when they do it virtually, they still need to get some feedback about their decision making, right? And how would you do it if you don't see the patient 1 year afterwards because he's coming in for regular care, and then you could update your records. And I think that's I would go with Andreas. That's a real challenge for some parts in Germany because you like the digital applications, the health applications. They only have sporadic possibilities to collect further data about their treatment success. So, yeah, I think that's so important for telemedicine.
Yeah. Thanks for all those encouraging comments. We're certainly not perfect. We're just getting pockets of data, and we use whatever data we have. For example, sometimes our PharmaNet data, in terms of prescriptions that they use, is not a complete record. So we still, just like in research, you try to get as perfect a set of data as possible, as controlled as possible. Administration data usually can be a little bit murky. It's a wrong diagnostic code, etc. So we have to live with all those limitations. In the real world, using these data at least give us some insights. And I think it's more important. In some ways, it's kind of like your all our watches, right? Tracking how many steps. It's not necessarily accurate, but missing 100 steps won't kill us. But the trend is more important than the actual number. So that, oh, wow, this year I'm walking more steps than last year. The trend is more important than the actual numbers. So I think the administrative data is important for us to track, knowing that there are limitations, but the trends is what we really need to look at.
Another question I would have in mind, in case anyone else wants to ask, you could even ask in the chat and I will read it. Another question I have in mind, like in Germany, we are eager to implement and have already started like a central health data space. And I'm not quite sure, do you have something similar in Canada, and is your service contributing to this database? And can you collect, so can you gather data when someone is calling? Could you have a look into that data space, and how do you do the authentication in that regard?
Thank you. So the health system in Canada is such that each province or jurisdiction, each province or territories is in charge of the health system. Federally, they do provide funding, and there's some services, such as service to our Indigenous population, to our police force, the RCMP is federal. Otherwise, most of the health services are jurisdictional province. And so in the province of British Columbia, I use the health data platform, which is the Ministry of Health Data, to do what we do. So that's helpful. Across Canada, so Ontario has their own system called ICES, and Alberta has a system because they now Epic is an Epic province. They use the electronic health record Epic, so it's easier to kind of track all those data. Nationally, there's a movement to try to link all those databases together, or what we call health interoperability, health data interoperability. Not there yet. And so there are some. We have an agency called Canadian Institute of Health Information, CIHI or CIHI. So if you look online, CIHI does try to track all through whole Canada and pick out from different databases to analyze a certain piece of information. But far from having one united system, or at least a federated system of data so that we can actually analyze it nationally. Hope that we can get there. We're not there yet.
I think it would contribute significantly, right, to the decision making and to the aftercare. Yeah.
Yeah. Maybe let me bring out the wonderful collaboration I had with Christian in one of the earlier studies about access to data, and also putting a chip. At that point, we're thinking of putting a chip on a card. How do you nationalize it? And in that case, can we get a minimum data set from each of the databases? So at least there's some commonality, like past history, medications, etc. I think that concept still holds in the interoperability space. But of course, if you actually have the ability to have the data all in a data lake together, and now with large language models like ChatGPT, you really don't need to predefine your minimum data set. You actually can use large language model to start helping you to look at the data in different ways. So I think the key now really is to try the data to be interoperable. I think that's going to be a really important step.
Initially, when you started talking about virtual physicians or nurses, I was, because I'm from education computer scientist, I was thinking about chatbots or something like that. And then I recap a discussion I had with a person working in telemedicine as general physician, and he was referring to his experience with chatbots and delayed communication, like half an hour later, the next response bit came in. Did you collected any experience in that regard?
Yeah, there is a chatbot, an 811, but it's the traditional one in a sense that you have to ask all 20 questions and then it come up with a probability. So really it's a version 1 chatbot where it's statistically driven based on guidelines, and you marry them together as a chatbot, right? And then the second generation of artificial intelligence is using deep neural network. You start to actually identify different kind of questions, a large database, and then with that deep learning network, you may ask question 1, and if question 1 is positive, you go to question 15. If question 15 is positive, you don't need to ask any more. You've got to go to merge, right? So that's the second generation. And now with large language models, especially with not just one AI, but multiple AI agents, or this whole agentic AI piece, you can actually accelerate a lot faster in this third generation. And so I think chatbot is going through its evolution very rapidly, and also increasing database, not just the data that we collect, even the patient's recording, natural language, the physician's recording, nurse recording, all those become really important pieces of data to help us move towards that kind of future AI. So in fact, Sebastian, you can give me a lecture on that one. I learned it from my data science colleagues. And so very, very exciting time for us to actually look at how AI can really evolve very rapidly to help us to move forward on that.
I would agree. There are some big chances, but still we have to assure quality assurance, right? Yeah.
100%.
Do you have a feeling, and my last question for this evening, do you have a feeling on slide 7 you distributed the different treatment groups you supported or suggested the peoples to? Do you have a feeling how many went to the greenish? So how much percentage of effort you kept from the clinics?
Yeah, 100%. So let me show slide 10. Slide 7 is the path, which is this. And then slide 10, that is the outcome of the physician in the middle column. So on the graph, the Sankey graph on the left, the breakdown of after we've seen the patient, where the nurses felt that they need to see a physician now or go to emergency now, we break down to about 21% emergency that they got to go. 9% they got to see a physician today, If not, go to merge, and then 40% stay home, about 30% follow a family doctor. That's a rough percentage, and it actually stay fairly consistent, plus or minus 3 percentage point over the last 4 years.
That's excellent. That's a huge percentage. Yeah.
That's
Thanks.
what convinced the government to make this a permanent line, actually, within about 2 years of restarting. So data has this effect too. Mind you, if it didn't show benefit, we should have shut down this line. I would say, it's a waste of money, let's move on. But it seems that there is return on investment, and we're calculating that cost at this point. So those are the factors that help government to make good decisions, to say, okay, in that case, continue, but modify it this way, etc.
Okay. Anyone else? Any questions for Kendall?
Sorry, I was a little late and I mistake or I don't have here, but I have visited before the homepage and read a little about Haiti and the other projects that they are releasing in your excellent research group. But the question or my question was or it is because the difference in Germany is that we don't have too many access to the data. I am more from the machine learning group here. We are developing right now some machine learning model for the emergency department too, and one of them is Connect ED, and we are trying to use cases then cardiac arrest out of hospital and polytrauma, but we our models are not very good because we don't have the sufficient data to make the training. And then my question is I think that is because in Canada it is not really, we cannot make a really translation directly because it is more here we don't have the electronic patient we don't have all the data pool that's required to make this kind of model. Is your data in any form usable, or it is possible to share some kind of data or not, or what is or how it's possible some collaborations or with.
Yeah, thank you, Sully. I understand the challenge that you and we face in that, because to look at, for example, out of hospital cardiac arrest or polytrauma, then come to emergency with mortality and morbidity data, you really cross several, at least 2, if not more, databases. You need the emergency department database, you need the pre-hospital database, what transport, etc. And then finally, you also need the patient's follow-up, which hospitals, where did they go? If it's all in one region, it's easier. But if it's a trauma happened in one region, the patient's being served chronically in a different hospital, again, that's where the challenge is in terms of outcome data. So that's challenge number 1. Challenge number 2 is that, we in the emergency department, this is different from this project, but there's a linkage there. So what I talked about is this pre-hospital data set that we are working on 811. But in the emergency department where I work in Vancouver General, again, we're looking at that particular set of database. And so that look at the emergency department after the patients arrived until the time that they exit our hospital. Now, we can correlate back a little bit to the pre-hospital on that, but we're not doing well on that part yet. And also there's some, you're probably aware, there's some international databases that are open for data scientists. For example, MIMIC, MIMIC.
Exactly.
So it reached the MIMIC 4th generation. That's from Brigham Women's in Boston. And so that type of data set can help us to start formulate, play, etc. But getting access to our own hospital, and again, that's a hospital database. So getting our own access can help. So there's no purpose at this point, and our hospital has governance so that they are planning to open up like MIMIC 4 but they're not making it available yet. A set of anonymous data anybody can access to play with it. We're not there yet, and so as a researcher, I need to jump through ethics to get that. Soli, I don't know whether that kind of answer your question, but
Yes,
certainly
no, thank you. Yes, we have made some models already with Mimi on Mimit ED, that's the special Mimit 4 ED too. And yes, we are our major lack of data is in the pre-hospital already, because in the emergency department we have the record data, and with medics here we have some access of the data. But yes, you are right. Or we're thinking to in pre-trained models or something like that. But okay.
Thank you.
Okay. So, Kendall, do you have a question for us to finish your presentation? Anything?
One, really appreciate the opportunity. Second, Christian, as I said to you, and I'd love to share with all of you, love to collaborate, because at the end of the day, you know, it's our corner of the world where we apply the system. There are certain things we learn, but we really love to collaborate in many different ways. One, on a clinical front, how can we improve the service? And in fact, in Germany, you have a very good health system, and so what can we learn together? Secondly, as far as data and machine learning, we know that more data is better than less data. And so with this diversity of data, again, how do we work together so that we can have a bigger set of data so that we can learn from it? And so for that reason, again, collaboration would be fantastic. So I look forward to the opportunity to do so. And Christian is my link, and of course, to be able to connect with all of you. So really want to thank you very much for this time.
Yeah. Great. Thanks, Kendall. So let's see if we have the new electronic patient record coming up, where you can actually donate your data. And so it should be easy to access it, but we're talking about next year. So yeah, so thanks a lot to every one of you for this great and fortunately very quiet session this time as opposed to last week. Yeah, next week we will have Tim Hahn here as a presenter, and we talk about artificial intelligence. So I hope to welcome you all again next Wednesday.